Okay, first, thank you for your kind introduction. Also, big congratulations to Chris and David for big prize. And I also like to thank the organizing committee to invite me come over here to share my study with you in this prestigious symposium. And I'm a rheumatologist, so I like to start with these slides first. So the milestone for the drug development in autoimmune diseases. So at the beginning, because we don't really know what kind of diseases we faced, so we treated patients, use non-steroid and anti-inflammatory drugs like aspirin and few others. When the immunologists tell us this is autoimmune disease, we start to use the DMA, disease-modified anti-rheumatic drugs, and including steroid and other and immunosuppressed drugs. The efficacy is good, but the side effects is huge. So that really means we need to use better drugs to treat the patients. So although we don't really understand the precise pathogenesis of the diseases, but we understand that at the end of the day, because high-level cytokine, which will cause the tissue damage and inflammation. So Manning and Friedman from Kennedy Institute back to early 90s, you developed Emblo, the first biologics and against TNF. So biologics start happens in our rheumatology society. So the efficacy is great and the side effect is minimum. And so we use quite a lot over the last 20 years. We learn lots. So two important lessons we learn, and we also can say that the information close to us. The first one is the early treatment, bad outcome. So early treatment, we need early diagnosis. But the problem is for our autoimmune disease, we can't do early diagnosis because we all use the criteria to diagnosis. For example, AS. AS is easy to diagnose, but we still use the modified New York criteria 84. So that means you need SI joint second degree and the damage by X-ray visualized. So this is, and can't be earlier. So we need diagnosis in this place. So in our rheumatology society, the biggest, project is that to do the early diagnosis objective. So we take advantage from the genetic study because AS and in complex disease are most heritable diseases. So, P27 contribute about 23%. Over the last many years, and many groups, over the last many years, many groups working together, we identify 116 genes that actually contribute a little bit for the pathogenesis. So that encourages us to do large scale the exome GWAS involve about 25,000 cases plus 71,000 and individual and health cross nations from Caucasian to Chinese and Iranian and Turkish, and that's led by the Matthew Brown and I. So we identify another 32 novel and low size, and we did lots of functional study, try to understand that. Take advantage from this genetic study, actually we can do polygenic risk score. So we take a polymorphism for the P27, few other genes we identify responsible for the pathogenesis of a disease. So we cross this 21,000 cases tenfold cross validation. So AUC curve can reach to the 0.95. That's almost perfect. So you see the early prediction and diagnosis sensitivity can reach to the 91 and 95. So that the sensitivity and specificity much higher than the past, the ASAS, and based on the clinical criteria. So that's the first, the objective early diagnosis for the rheumatic disease already published. Second one is rheumatoid arthritis. That's led by the Suma from Harvard and Okada from Japan. So we're also involved in that study. Many of rheumatologists involved in this big study. So this is the field in our rheumatology society. We we really need to do early diagnosis, objective diagnosis. The second lessons we learned from here, from the study, from the biologics, we still have a proportion patients not respond to the biologics. That means we need other drugs, need to better understand the pathogenesis, so we can develop and other, effective treatment. In the meantime, whether or not we can use cell therapy. So we think about that quite often, but we didn't sort of, encourage us to do that over the, the stem cell for others. But CAR-T cells maybe is the way to go. You see the CAR-T cells, we can see that's a couple of months ago, we checked the map. We can see that the trial in international trial, it's about 1,591 cases and trials going on, most of them in China. So we see CD20 partially work in the lupus. Also, we can see CD20 partially work in the leukemia. So that means, CAR-T must work in somehow because the CAR-T for the leukemia and other B-cell related tumor quite effectively. So we think about it in 2018, and however, we didn't pass the ethic. And also in 2019, and pandemic for the COVID-19. So we failed to do that, and we're pleased to see that George here, he's a pioneer to put this in the cases. So he published and case by case in all other leading journals. This is open the avenue for us. After that, we can quickly to say that in China we have 12 registered trials. So we are in China always fast follow, but not really in the beginning to do that, the pioneer to do that. So we use a different approach, and this autologous trial. We think about whether or not we can use other alternative approach. So we think about and allogeneic, because we think the autologous trial and the CAR-T have some issues. I'm not saying that the autologous CAR-T is not good, particularly George is here, but we still face a few problems here. First is QC, because that's individualized products, even same patient in same company, different time, and actually you can get same products. That's QC. And the second thing is that we need to stop the treatment for the patients. Our patients, particularly for very sick patients, it's feasible to stop the immunosuppressed drug before we do the trial. And the third one is cost, because in China, costs about more than 1 million RMB. It's not affordable to most cases. So that's a problem. Another thing is, I think the most important problem is that the T-cell defect in our autoimmune diseases, because our autoimmune disease patients always receive intensive immunosuppressed drug. Also, when you have autoimmune disease, always have the T-cell defect. Like we see the kids have the sort of autoimmune diseases, always have immunodeficiencies. So let's always combine together. So that make us think about use different approach for the allogeneic one. So we start collaborating with our colleagues from different institutes, like Du Bin from Shanghai Normal University, and Zhang Yonghui and Lin Xin from Tsinghua University, Yang Luhan from the Qihang Biotech, and Chen Qixu from China Academy of Sciences. We use different products. We use the basket, the trial for 6 B-cell related diseases: lupus, scleroderma, myositis, APS, Sjogren's syndrome, and vasculitis. As you may already see, the first 3 cases already published in the Cell. That's draw quite attention. So the Crafoord writer and the editorial for this trial for say that shifting for the autoimmune disease, also headlined by the Nature, and say that this world first trial. And we also pleased to see that our paper was selected by Cell Line. For every 10 years, they select some landmark paper. In 2024, select 3 papers. One is from us, another one from China for the diabetes study. So we are very pleased to see that. So that's quite encouraging to us. So in 2024, we did another 33 cases for the allogeneic CAR from a single center. So I'm going to tell you and share you the unpublished data. And the first one, we still use the same products we published in the Cell and collaborate with Dubin. So that product is from donor blood, and then we purify the T cells, and then we transduct the CD19 FMC63 currently most CAR-T and antibody used for CD19 is FMC63, and not many people know FMC stands for what. FMC stands for Flinders Medical Center, and it just happens 30 years ago, I did my PhD in that department in South Australia. Professor Hedy Zola from our department produced all kinds of CD and antibody from CD1 to CD100s. So CD61, 63 is the anti-CD19 antibody. After get CAR over there, and then we use the Cas9 to knock off MHC in certain degrees. That's the key issues over here. If you completely knock off, you can induce NK responses. If it not enough, probably it will induce the rejection. And we also did other, editing. But important here is that from one single donor, 100 mils, we can get produce about 200 batches ready for use, 200 cases. So that was called out of shelf. So we use these products, we transfusion to the patients. We can see the CAR proliferate very well, allogeneic one. Even in the 90 days, we still can see the CAR over there. And importantly, they can delete the B cell very well, effectively delete the B cells. And then you can see the product works. So we want to see the efficacy. So for these patients, we did 6 patients already reached to the 6 months. So we can see the crisis evaluation for the efficacy. That consists of 5 components. We can see all patients reached the remission, apart from the case 2, and they little slow, about 2 months they reached remission at one point, because we only allow to treat the very sick patients that fail to all the standard treatment. So that patients, is very sick. But overall, we can see they all reach the remission over the 6 months. And then we can evaluate the skin, use ultrasound, objectively evaluated. Actually, when our nurse, after 1 month, and they can easily put the needle in the skin. Before, because scleroderma, the skin like laser, very difficult to put in needle. And the patient feel very relieved, they can easily open the mouth. And then from here, we can see yellow is very thick, and the green is more and more soft. So objectively, we can see the skin improving dramatically. And then, surprise to us, also we can see the lung fibrosis resolved. And we have the patients already reached 9 months, completely fibrosis resolved. Let's change our concept. Before, we never believe the fibrosis is going to reversible. So now this is really changed the concept. We can see the fibrosis and resolved very well. As I said, we have the patient very sick. The first patient, we can see the left ventricle in the corner here, very sick, and edema, inflammation over there. After 3 months, we can see the heart becomes smaller because edema and the inflammation gone. So our cardiologist immediately tell us the heart becomes smaller, and the fibrosis also and resolved very well. And then we do the biopsy for the skin. We can see in the derma, we can see lots of fibrosis over there. After 6 months, we can see, and the fibrosis started resolved. And then we go to small ventricle, come back. And then we stand for the CD19. We can see that before the treatment, a lot of B cells over there. But after 3 months, the B cells started to disappear. And also, we can see the information improve dramatically. So we did all 6 cases, and almost similar outcome. And then we can see the antibody. Antibody dropped significantly and in cases, but immunoglobulin didn't have much change because we didn't target on the BCMA, didn't target on the plasma cells. So all the other antibody against infection, pathogens antibody or vaccinized antibody didn't have any changes. So that's good for the immunity, protect the patient's immunity. And then we did the single cell sequences for the skin and also for the blood before and after treatment. I only show you one, the data here from the skin. We can see that, monocyte significantly dropped after treatment. So the skin becomes more and more pale and more and more beautiful. And you can see that the keratinocyte increases significantly. That means they become more and more normal for the skin. So this is already done for 6 months data for these 6 cases. So we're going to submit it very soon. And then we did for the other, use another product, collaborated with Yang Lu Han. Actually, she is the first author for the Cas9 when she was in Harvard, work with George Church. And the product is iPS-derived CD19 BCMA CAR-NK cells. They knock in the 6 genes, knock off the 3 genes. So this can be a larger scale to product the iPS-induced CAR-NK. So that's the 3 months data. We can see that the baseline and after 3 months, that's completely changed. So patients are very tearful, and because this is just like a change of the life. And we also feel very pleased because when we see the patient's relief, we also feel very pleased too. So, and then we can see that the skin also have a significant change. And then we can see this, and the skin, we can see before the treatment, a lot of fibrosis over there. After 3 months, the small vessels come back, and also the fibrosis is resolved. And also the similar observation occurred in the lung, and the fibrosis and resolved. And then we did the spatial and proamics. So we detected for the blood also with the skin. The skin we cut into 4 parts, and epiderma and the baseline, also the glands, and also derma. So we can see, and we can see after treatment, the principal component analysis can see completely different. Also, the hemamac we can see completely different. And then if we look more carefully, and let's derma change, only related to the vessels regenerated proteins get more and more. And the protein related to the resolved fibrosis also, and started to change. The similar things we can see in the blood from the serum, and then we can see like C1QR1, that's related to the generated vessels, and they increase. And others like ELAN, they related to the resolved of fibrosis also changed. And the similar things we can see other proteins related to activation of the T cell and B cells significantly dropped too. So this already sent to the cells, and last night I sent back for the revision. I hope they can be accepted very soon. And then we did more cases for the lupus because people more like to see what's happening to the lupus. So we have larger cohort of lupus. So we compare with different products. That's all very sick patients, 20 years for the patients, and they have the proteinuria, never got dropped. But after treatment, different products we can see all the proteinuria and significantly dropped to the normal levels, and then we can see the clinical efficacy also very good. And then we treat more cases with the STAR-T. The STAR-T we collaborated with Dr. Lin Xin from the Tsinghua. The beauty for this product is that we replace alpha-beta chain directly by the anti-CD19. That's inside precisely the insect. So in that way, so we can avoid the GVHD. Another important thing is here, STAR-T already published for the cancer research from the autologous CAR-T. So they can knock off the MHC, so we can easily use that allogeneic CAR became to generate and allogeneic CAR. So use this CAR, we treat about more than 10 cases, 6 already reached 6 months. We can see that, from different angle, from the different criteria for the efficacy evaluation, we can see and slider and different and evaluation, we can see drop significant because they are very sick. And the slider can be more than 20s, and then they drop to the almost normal levels. And also, in the same time, all the antibodies dropped too. and the C3, and the complement C3 and the C4 elevated, become normal because the information and changed, so that the complement kept getting to normal. And the important, we also can see the 24 hours urine proteins drop significant. All these patients treat for many years, no matter what kind of drug you use it, they never get dropped to normal. So that's quite encouraging. And then we also did for the, the biopsy for the kidney. We can see that the kidney before the treatment, all fibrosis over there in the left corner. And then after 9 months, we can see the kidney glomerulus coming back. So we never saw this before for the biopsy. And the immunocomplex also disappear. And the second case is 5 months later, also we can see the coming back. So this is a significant change. We never see this before. And then we did a single cell sequence as well for these cases. And before the treatment, after treatment, in different time point. And then we did the subclass and the T and B cells in 16 categories. So they have lots of changes. And I focus on the B cells because here's more B cell and the biologist here. So with a subclass in the 6, the subtype of the B cells here, and then we see the changes over here. We can see left and the diagram, we can see before the treatment, we have all kinds of B cells over immature, matured, and unswitched and switched B cells. But after 6 months, we can see here, only have naive and immature B cell over here. So reshaped completely. Because we did a single cell sequence, we know the repertoire. And then here, before the treatment, we also can see all kind of IgG, IgM, IgD, the type of the, the B cell over there. But after 6 months here, we can see only remainder is that, the IgM and IgD, no matured IgD over there. So you can see this is totally reshaped, the B cells. I think George is going to talk more about these changes. So lastly, we want to share the safety issues for the audience here because this is important for clinicians. So before we do that study, actually, we have no idea about the patients because we're quite nervous because we can see the hematology department for CAR-T, and it's not that easy. So totally surprised to us, actually, after treatment, we didn't see much side effect apart from leukopenia because we do the precondition. So we have the 2 weeks leukopenia. So that's a critical time for us. If we not isolate the patient properly, they get the infection, that's going to be trouble. Otherwise, it's quite good because we see the cytokine didn't increase dramatically. So let us know that actually autoimmune disease is quite different from cancer because cancer patients, they have burden for the, high burden for the, the tumor cells. For our autoimmune disease, only small proportion of the B cells are affected. So they're not going to get the high level of cytokines over there. So what's next? So we still carry on the work. So we collaborated with medical groups in China, in Shanghai particularly. So we try to do more works. And so we want to understand more, like different additive, whether it's better or not. We compare with different products. We try to understand, pathogenesis, also the mechanism behind this. And we also try to identify new target. And apart from CD19, apart from and others, and whether or not we can get a new target. But at the end of the day, we really want to push to the R&D, to translate it to the clinic. And finally, I like to acknowledge the staff work with me because they work very hard. They not only need to see all kinds of patients because we are large clinics and we face lots of patients daily. So they need to do the clinical work, see all kinds of patients. But we focus our research mainly in ankylosing spondylitis and rheumatoid arthritis, part of lupus. But we also do a lot of CAR-T work. And also we have lots of students involved in our basic science study from Tsinghua and also from my university back to Shanghai. Thank you so much for your attention.